Good morning, all. I am Dr. Sridhar Smith from Department of Constitutional Medicine and Environment. I'll be discussing about vital pulse therapy today. Let us see the rationale of doing a vital pulse therapy. It is important to maintain the healthy state of the pulse, and it is preferable to doing an endodontic treatment as it is more complex and time consuming, and also preserving the vitality of the dental pulp is important when keeping a tooth with exposed pulp, particularly if the tooth is immature and root formation is not yet complete. Maintenance of a healthy pulp allows continuous root formation and also helps in restorative dental formation. Before we start and go in detail about vital therapy, there are few terms that would be necessary for you to understand. Infected dentine and affected dentine are two such terms. Being a third year or a second year or a 10-year student, it is enough if you know the basic difference between the infected and affected dentine. Particularly, infected dentine is something that is very soft and leathery and can be removed with an easily removed with an instrument. And these contains microorganisms or the toxin and cannot be remineralized and therefore has to be removed during cavity preparation. Whereas an affected dentine is something which is very hard and it is not easy to remove with an instrument and also do not contain microorganisms and can be remineralized. For this reason, it is easy to it is better if we can retain the affected dentine during a cavity preparation. The other two terms are reactionary dentin and reparative dentin. These two terms are commonly seen during our vital pulse therapy session. The difference between the two terms are they both are firstly tertiary dentin, but reactionary dentin is produced by odontoblasts as a response to a very mild injury. So during a mild injury, the odontoblasts do not completely die and they survive, and in such cases, the odontoblasts produces a tertiary dentin called reactionary dentin. Whereas reparative dentin is produced when as a response to a severe injury. Here, odontoblasts die locally and differentiation of new generation of odontoblast-like cells from progenitor or stem cells happen, and this give rise to a tertiary dentin called reparative dentin. Remaining dentin thickness. What is remaining dentin thickness? It is the amount of the dentin that is present between the floor of the cavity as well as the pipe chamber. So the amount of the dentin that is remaining between the floor of the cavity preparation and the pipe chamber is called remaining dentin thickness, and ideally it should have a minimum thickness of 2 millimeter up to 0.5 mm. It means there is a good prognosis. Whereas whenever the remaining dentin thickness becomes less than zero point 0.2 or zero point 0.5 mm, then reactionary dentin is reduced due to the decreased odontoblastic activity. Sufficient RBC protects the pipe from vibrational injury and frictional heat which is generated when we use a burr, especially when there is no coolant. In such cases, there is a lot of heat produced and also there is a lot of vibration also produced. In such cases, the sufficient RBC will protect the pipe from the injury. It also protects the pulse from cytotoxic injury, which may be due to acid exchange of restricted material, as remaining dentin thickness maintains the buffering action of dentin. Now, according to American Association of Endodontists, vital pulse therapy is defined as treatment aimed at preserving and maintaining pulse tissue that has been compromised by trauma, surgery, or restrictive procedures in a healthy state. There are four types of vital pulse therapy. Firstly, indirect pulse gapping. Second one is direct pulse gapping, partial pulpotomy, and finally you have full pulpotomy. We will discuss each one in detail. Firstly, what is indirect pulse gapping? And indirect pulse gapping. According to Grossman, a procedure where the deepest layer of the remaining affected caries dentin is covered with a layer of biocompatible material in order to prevent pulpal exposure and further trauma to pulp is called indirect pulse therapy. There are other definitions which are also given by Angel as well as McDonald. You can refer and quote any of these definitions in your exam. So So far, doing indirect pulse therapy, we have to see the history and the other clinical examination of the patient. So, the diagnostic tests that we do are to select the patient for indirect pulse therapy are firstly the history. The patient complains of tolerable dull pain with mild discomfort associated with teething. There is mild to moderate pain on thermal stimulation. There is no history of spontaneous or excruciating pain. Clinical examination. On clinically examining the tooth, there is a large carious lesion without any frank pulpal exposure. The term frank pulpal exposure is very important. So whenever there is no pulpal exposure, direct pulpal exposure, it is then we use a vital pulse therapy. There is a positive response to electric pulse sensitivity test, thermal stimulation, and cavity. The tooth responds normally to percussion. And on radiographic examination, we see a large carious lesion without any pulsal exposure, and there is a positive response to electric pulse sensitivity test, thermal test, as well as test cavity. And the tooth responds normally to percussion, and there is an intact lamina dura, and there is no periapulpal changes. Clinical procedure. How do we treat a tooth with a large carious lesion by using indirect vital field therapy? So whenever there is a large cavity lesion, the soft infected dentin is removed first and the cavity is restored with a pulse capping agent. The commonly used pulse capping agents are calcium hydroxide based materials, any bioceramic, MCA based materials, or even biodentin, and there are many other more. So using these materials, first we give a small layer of the pulp capping agent is placed on top of the affected dentin. After 3 weeks or up to 6 weeks, the patient is recalled. We remove the temporary restoration that has been placed and we examine the floor of the cavity for color change and if there is any remineralization is occurred. And also we see about the patient's clinically we examine the patient and ask if there is any discomfort. And if there is no problem, we continue with the final restoration in the second. So this is a diagram to explain how indirect pulse therapy has been done. Here first the kidney, the soft leathery part is removed and the affected dentin is left behind. And on top of that, we give a pulse capping agent and the patient is asked to return after several weeks. And on the second appointment, we examine the patient and assess the vitality of the tooth and the final restoration is placed. We use a diagrammatic representation. Next one is direct pulse capping. Why? What is the difference between direct pulse capping and indirect pulse capping? In direct pulse capping, there is a exposure of the pulse, whereas in indirect pulse capping, there is no frank pulsal exposure. Direct pulse capping is defined as a procedure in which the exposed vital pulse is covered with a protective resin or base directly placed on over the site of exposure in an attempt to preserve the vitality of the tooth. What are the indications? Asymptomatic. No spontaneous pain, normal response to thermal testing, and pulse was vital before the operative procedure. Small exposure, that is less than 0.5 millimeter in diameter. Hemorrhage from the exposure site is easily controlled within 10 minutes. The exposure occurred in clean and uncontaminated site. Atraumatic exposure. So this is a flow chart to determine how to differentiate between a direct and indirect pulse therapy. Deep series, if there is a deep series lesion, we first anesthetize the tooth and we place a rubber band and isolate the tooth. After which we remove the series. The infected dentin can be easily removed with a rounder or as well as a spoon excavator. And also the any overhanging enamel and other dentin is removed. And we examine the cavity and we see if there is any pulpal exposure or if there is no pulpal exposure. If there is pulpal exposure, then we have to take a call whether it should be a direct pulse capping or if it should be a partial pulpotomy or full pulpotomy. Whereas if there is no pulpal response, I mean there is no pulpal exposure, the tooth can be treated by indirect pulse therapy. So here the steps in indirect pulse therapy would be to remove all the infected dentin, keep the affected dentin, and place a layer of pulse capping agent, which is normally a calcium hydroxide based material, orange bioceramic material can also be placed, and cover it with iron. Wait for 3 to 8 weeks. After which the patient is recalled and the cavity is isolated and the sensitive material is removed, and further examination and excavation is done, and if everything seems well, we can give a permanent restoration. Now, what are the factors affecting direct bulk clotting? It depends upon the size of the exposure. Like I said, it should be 0.5 ml or a pinpoint exposure. Bacterial contamination. Bacterial contamination increases as the time from exposure increases. If the pulse has been exposed for a very long time, then the bacterial contamination is bound to happen. Duration of exposure before treatment. So that exactly like I said, the more the duration, more the bacterial contamination. Caries versus mechanical exposure. If the focal exposure has occurred by caries lesion, that means there is going to be some kind of bacterial infestation, as well as there is going to be some kind of inflammation. Whereas if it is an hydrogenic mistake or due to some mechanical exposure that happens, then the chances of pulpal inflammation is less compared to the caries lesion. Then if there is any micro leakage from the permanent restoration, and also the area of exposure. Clinical decision making chart for management of focal exposure. If the exposed pulse has been if it is a very large exposure, for example, if it is more than 1 to 2 millimeter, then complete pulpotomy or even pulpectomy should be undergone. Whereas if it is a very small pulpal exposure, then direct pulse capping would do, or even specs pulpotomy would do. If the duration between the exposure and treatment is very large, for example, if it is only up to 48 hours, then specs pulpotomy can be done. Whereas if it is more than 48 hours, then pulpectomy or complete pulpotomy has to be undergone. Duration of hemorrhage. If the hemorrhage has happened only for 10 minutes, then direct pulse capping, even specs pulpotomy can be done. Whereas if it is for more than 10 minutes, then complete pulpotomy or even pulpectomy has to be done. Second direct pulse capping. Pulpal exposure. If pulpal exposure has happened, first anesthesia and rubber band isolation is done, and we control the hemorrhage using 6% sodium hypochlorite, and the hemorrhage has to be controlled within 10 minutes. And once the hemorrhage has been controlled, a calcium hydroxide based material can be placed, on top of which RNGIC can be placed, and a final restoration. The favorite amalgam or composite can be placed. Whereas if we uh, choose to use NPA instead, then we have to mix NPA based on the manufacturer's instruction and place a minimum thickness of 0.5 NPA directly over the exposed pulp. And once the NPA has been placed, a moist cotton or even a gauze pellet can be placed over the NPA, and functional restoration can be given. After 5 to 10 days, the patient can be recalled and the functional restoration can be replaced with a permanent restoration. So these are the diagrammatic or pictorial representations of how direct pulse capping is done. Next one is pulpotomy. Pulpotomy is defined as a procedure in which a portion of the exposed or exposed coronal vital pulse is surgically removed as a means of preserving the vitality and the function of the remaining radicular portions. This procedure is similar to the concept of vital pulse therapy, direct pulse capping, except in the amount and the extent of the pulpal tissue which is removed. That is, in a pulpotomy, as the term suggests, some amount of pulp is being surgically removed. That is, if there is a larger pulpal exposure, for example, more than 1 to 2 mm pulpal exposure has happened, and if there is a time duration between the exposure and the treatment time is more than 48 hours, we assume there is a little bit more of bacterial contamination up to the cervical area. In such cases, we remove a large portion of the pulp from the pulp chamber. That is, the coronal portion of the pulp is removed, and the concept of direct pulse capping is followed. That is, first we give anesthesia, we isolate the tooth using rubber band, and we try to control the hemorrhage, and we can analyze the pulpal exposure. Once we analyze and we come to understand whether it is a large pulpal exposure, We use a burr or even a spoon excavator to remove the complete pulp from the pulp chamber, and a pulp cutting material like calcium hydroxide or NPA is placed on top of it, and it is then completely restored with a temporary frustrated material. So the objective is to of doing a pulpotomy is to maintain the vitality of the radicular pulp and relieve pain which is mainly caused due to pulpalgia as well as inflammatory changes in the tissue. And by maintaining the vitality of the tooth, we can expect the continued root formation in case of immature permanent tooth, and normal apoptogenesis can be achieved. The indications for pulpotomy are there is a serious or even a mechanical exposure in permanent tooth with incomplete root formation, traumatic exposure of longer duration where coronal pulp is likely to be inflamed. Pulpotomy is indicated in pulpally involved permanent tooth, and teeth of children in which the root apex is not completely formed. Whereas it is contraindicated in reversible pulpitis, and when the patient responds abnormally to heat and cold test, and if the pain has been for a very long time, it is a chronic pulpalgia case, and there is tenderness on percussion or there is any periapical changes, and when there is a constriction or calcification, or if the pulp chamber has receded from the normal level.